those things that maybe at some point, we could get some discussion about, you know, what have those traditionally looked like, and are there things on the wellness side we could maybe look to change that demographic a little?
I think you're gonna be hard pressed, because the
Yeah,
age
maybe.
plays such a huge role in that. And that doesn't, it
sure.
only goes one way.
I'm sure, but you don't know.
Yeah,
And you're not, I mean, you're typical of many of the counties that I work with. You have somebody that comes in, they stay forever till they retire. And the demographics, you know, everybody gets older every year, and unfortunately, that's just the way it happens with a lot of our cities and counties, and they don't leave typically. So but you're going to be seeing the baby boomers starting to retire more and more, so you're going to see that turnover at some point. But again, there's still those that once they're in a job, they stay put. So. Then the renewal decision there toward the bottom, expected claims change 0%, so we're not expecting claims to change over the next renewal period. Your network access fee and admin fees are increasing to 4.1%. Individual stop loss and aggregate stop loss is increasing to 3.456%. And then overall change to estimated suggested rates, and that's where we suggest that you fund at. And that's 0.57% increase. And then your dental increase is 10.86%. You self-fund your dental, so it's mostly impacted from claims costs. We've seen an increase in dental claims over the last year. There's no change to the admin fee on the dental claims, but we're seeing more utilization, more costs as far as the dental.
Self-fund all the dental, is that what you said?
Mm-hmm. Yep.
And we've seen that in our balance really, that we haven't been building, it's been, on the dental, it's been kind of hanging tight.
Yep. And the dental plan, there's a benefit period maximum, so you have a maximum liability that you would pay out anyways, and it's not a huge amount, but we have seen an increase in claims costs. Wellmark experience trend is running at 8.5%. Health alone is 7.5%, and pharmacy is 10.5%. This has come down about 1% from last year, so we're starting to see that trend come down or start level off a little bit more. Hopefully that will continue, but it just depends on claims costs.
Does it seem like we're still optimizing usage of generic drugs?
Yeah, and I have some reporting that will show that.
Okay.
The generic drugs utilization is very good. It's those specialty drugs where there's not very many generics.
I see that. It's kind of high.
That's where we're seeing the impact, is those specialty drugs. And as far as updates, we've been reviewing mental health parity updates to make sure that you're in compliance with those benefits, and right now you are, but we are doing a retro review of that, and if there's any changes that need to be made, I'll follow up with Nancy, but right now there is no changes for that to make sure you're in compliance. There's an ABA therapy mandate that was implemented in 2017, so applied behavioral analysis, which is for autistic children. The state passed that law last year, and since you're a public body, you have to follow the state mandates. And basically, it covers training and schooling for autistic children under the age of 19. Last year, at 7/1 of 2018, we did migrate to a new claims and enrollment system. Everyone received new ID cards. And at that time, we started following the ACA preventive guidelines. So what that means to you is we follow what the government mandates as preventive service, and those preventive services are covered with no member cost share. Now, one of those was a 3D mammogram, and when I spoke with Nancy, she said that she wanted it covered at 100% with no member cost share, so we did make that update. Going forward though, when the government does make some changes, we will follow those guidelines. So that could mean that if you had a test last year and it covered at 100%, you may have some cost share going forward. An example of that would be some of the lipid screenings and some of the blood work that you get along with some of the preventive care. You may have to pay a co-insurance amount. It's just not going to be covered at 100% going forward. So I just want you to be aware of that we are following those guidelines, and there could be some impact to some members. There is a list of covered services available out on the Wellmark website, or they can go to the Health and Human Services website to find out what those screenings are. Also on April 1st, we implemented an opioid utilization management program. And basically what that does today is anyone that was taking an opioid previously is going to be grandfathered into the program until they make changes. So if they increase their dosage, get a refill, then at that point they're going to have to go through, well, if it's not an extended release drug, they would only get a 7-day supply. So I know today, if you have a surgery or something, they'll give you a 30-day supply oftentimes. Now going forward, they'll only give you a 7-day supply for pain medications, those that fall under the opioids. If you're a cancer patient or somebody that has a chronic illness that has to have some pain meds, those are not impacted at all. There's no limitations for those people because they need the medication. If it's an extended release opioid, a prior authorization has to be done by your doctor. So it's just more oversight by your physician to make sure that you're not getting too many of these medications when you don't need them. And then just some recommendations. It's not something that you have to do today, but it's something to think about going forward. Today you have a common accident deductible that is included in your benefits. And do you know what a common accident deductible is? Okay, so a common accident deductible is not something that we see happen very often, but it would impact a family. Say if they were in a car accident and they were all hurt, they all had to go to the hospital, they would only have to meet the single deductible on the plan. They wouldn't have to meet the entire family deductible. So it's a savings to where the member wouldn't have so much out of pocket. They still would have to pay co-insurance after that deductible has been met up to their out-of-pocket maximum, but that family deductible would not have to be met. It's an older benefit and something that there's no cost to claims cost or impact to claims costs for you because we don't see it happen very often. Another is to remove the Wellmark to Wellmark deductible out-of-pocket maximum carryover, and what that is, if you have somebody working for the city and they come to you and start working for you, any deductible that they've met with the city would carry over to your plan, so they wouldn't have to start over again. It's not saving you any money, but saving the member money. But it's you as a self-funded employer are paying more in claims costs for members that have that. So it's an older benefit. We're starting to see it go away, and something that we would recommend that you remove that. And then today you have dental coverage. You have accidental dental coverage under your health plan, and our new standard is to cover that within 12 months. And you have the separate dental plan too that would help that. So it's not something that's going to impact you as much since you have that separate dental plan. But today under the health plan, if somebody is in an accident and has an injury to their mouth, it's covered under the first 72 hours that they've received it or they had the accident. They have to go see a dentist in that first 72 hours, and then it has to be completed, I think, in 30 days. This would just extend that because a lot of times it takes longer than 30 days to get that fixed because they have to wait for swelling or some surgeries and things like that to happen. No cost of claims or impact to claims to add this to a 12-month period, but it's something to think about that just makes sense going forward. And then change to cover all specialty drugs or participate in the specialty pharmacy program. Today you have injectable specialty drugs covered under health and non-injectable specialty drugs covered under the prescription drug program. I would recommend to move all of that to the pharmacy program. It's not going to be an impact to the member except that they're going to just pay a copay for those specialty drugs rather than having to meet deductible and co-insurance. But there's better utilization management under the drug card than there is under the medical part of it. Also under the medical part of it, the way it works is a doctor will order the prescription and then administer it to the member. And sometimes the doctor will charge more for that prescription so that they help cover some of their overhead. So it can be more expensive overall to have it covered under the medical. There still are some medically benefited drugs that are covered under the medical, but we can move all those specialty drugs out under the pharmacy.
It's gonna be more expensive for us or for the,
For,
for
well,
the insured? Because if an injection is given during a doctor's visit, I would not consider that prescription. That is part of the doctor's visit. You're already paying a copay for that doctor's
Yep.
visit. And if an injection or a procedure that is done during that visit is not covered, then they're gonna have to pay another copay
no,
for the prescription?
no, well,
Yes, they're gonna double
yeah,
pay.
they would double pay in that aspect,
And that's ridiculous.
but
It
it's,
happened during the visit that they already paid for.
right, and it can, but what it is happening is the doctors are upping the cost of the prescription drug, and it's costing you as an employer more money because of that additional cost. Where on the pharmacy benefit side, the member would go to the pharmacy and get the prescription and pay their copay and take it to the doctor and have it injected there. And it's totally up to you on what you want to do, but we're seeing that as a self-funded employer, you are at more liability when it comes to having those services covered under the office.
You had mentioned, what do you mean by utilization management? You get better utilization management, you said, what are you talking about?
Utilization management is prior authorizations, step therapies, things like that. Under the pharmacy program, we have those in place for certain drugs, and a lot of those specialty drugs fall under that category. Where under those medically benefited drugs, they're not as medically managed, they don't have the access, or they don't have to follow through with that criteria, just to make sure members are taking what's best for them. I mean, if some of the drugs, when I say like a step therapy, they have to go through a process, usually to try generic, see if it works first, and then there may be some other drugs that are just as good at a lower cost. And if they work through those first and one of those works, then the member stays on those drugs until, unless it doesn't work. Now, if those that don't work, then you're going through the process to get to maybe a more higher cost drug, but they have gone through the steps to get there. They can still get there if something works better, but it's just a way to manage the costs for some of those higher dollar drugs, because a lot of them do have generics available. An example I can give you are some of the acid reflux. You can buy them over the counter, a lot of them over the counter for those. And you may be paying $20 for an over-the-counter medication, and if it works, great. But if you have a condition to where those don't work, and you go through your doctor and you've tried those and you've gone through the process, then you can get a prescription that does a better job. And that's called the step therapy process. You just have to try other medications. If they don't work, there's an option for you. If they do work, then there's no need for you to go on to the higher cost medications.
So basically, insurance companies are telling doctors how to be doctors, how to do their job.
We found that the doctors don't always know what's available because they are inundated by the pharmaceutical companies, and the pharmaceutical companies want them to sell their product. And members also see the commercials on TV, and hey, that sounds like that would help me. I don't care how much it costs. They go to tell the doctor, and the doctor says, okay, I'll do it. But they have access to our list, and we provide education to them. And in most cases, a generic can be utilized. I'm not saying in all cases it can be, but it's just a way. The doctors are busy. They're busy just like you are. They don't have time to read everything that's coming down.
They spend way too much time with these peddlers from the drug companies. I've seen this happen multiple times when I go to doctor visits. I mean, it takes a lot of their day away from what they can spend with their patients. It's all about selling these drugs.
That's part of it, but there's also, and I've seen it firsthand, to where you go in for treatment and the doctor throws his hands up in the air and says, I'm sorry, I've gotta ask your insurance company if I can treat you properly.
Yeah.
That's BS. Insurance companies are not doctors,
No, we're not, and we're not trying to be.
so don't tie their hands, that's what I'm saying.
Well, then, that's fine, but if you don't have utilization management in place, if you don't have these therapies in place, then your claims costs are gonna increase substantially as a self-funded
They
employer.
already have,
But-
and they only keep going up and the service keeps going down. Pretty soon, insurance companies are gonna push themselves out of business, cause there's gonna be no use in having it.
Well, that's a benefit that you can look at changing at some point. Overall, specialty drugs have been going up. We do have, we have preferred vendors for specialty drugs that we use. And today, your members can use anybody. Did you have a question?
No, I'm just,
Okay.
I'm interested in what.
Today, you can go to any pharmacy, usually they're done mail order, because specialty drugs have special handling. But, by using one of the preferred vendors, there is better medical management and also more personalized care for those specialty drugs. And we use CVS Caremark, the mail order, and also Hy-Vee Specialty Pharmacy, which is mail order. And, they work with the members, they're participating pharmacies, and that, member doesn't pay anything, or pays using their credit card, since it's all done mail order. And then they will call the member the day before those medications are shipped out, just find out where they need it shipped. You know, they can have it shipped to their home, to their work, they can have it shipped to a CVS or a Hy-Vee pharmacy if they want to. But they still have access to the medications, it's just limited to those preferred vendors. And again, there's more savings as far as claims costs for you to move that way, because they have worked with us and with the pharmaceutical companies to ensure that they're getting the best discounts for those specialty drugs. So that's an option that's available to you too. And then, you know, at some point, today you have two lower deductible plans for your benefits. The lowest one, I know last year you dropped the $250 deductible plan. And for this year, maybe at some point, you only have, I think, 19 people on that $400, $800 deductible plan. And at some point, maybe reduce or move away from that to have the higher deductible plans.
Do we know when our people left the lower deductible plan? Is it the same 19 people chasing the bottom up?
Yeah, but to me, I think that plan is gonna get to the point where it's gonna eliminate itself, because Walmart has a rule that we have to have 10% in any plan, and we're 10% of our people, and we're just barely at 10% now, so instead of us being the bad guys and taking that program away, I think if we wait a little bit, the rules are gonna take that plan away all by itself, so.
If you turn over to the next page then, this first self-funded final renewal rates, this is Plan B. This is your 500 single, 1,000 family deductible plan. You have the most people on this plan, 115 contracts, 54 single, 61 family. And then again, there's no change to expected claims. And estimated suggested rates are increasing the 0.57% overall. So it's based on the entire plans. The next page is your Plan C, which is the 1,000 single, 2,000 family deductible plan. You have 50 members on this plan, 37 single, 13 family. And then if you turn over to the third page, then this is your lowest deductible plan. It's 400 single, 800 family, and you have 19 people on that, 13 single and 6 family. And the estimated suggested rates again are what we would suggest that you fund at. As a self-funded employer, you can fund at any level, but those are our recommendations. The estimated maximum liability to fund that would be the maximum amount that we would suggest that you would fund at.
And just as a, kind of as a side note, so you know, when we budget and we do union negotiations, we typically do that before we have final numbers. And so I sat down this weekend and calculated it out based on what we put in the budget and what we negotiated. We're funding at just above 99% of what they're suggesting, so we're really kind of where we need to be, so.
If you turn over to the next page, then the drug or the farm dental plan. So you can see this is for the current or the prior period and the current period, and you can see that claims costs have gone up over 8%. And then if you turn over to the back page, then it gives you the expected claims and estimated suggested rates, and those are going up over 10%, about 11% overall.
What's driving that, do we know?
You know, I can pull reporting to see what is driving it. I
think we've just had increased usage, and that's what it looks like.
And I can narrow it down to see what it could be, but right now, your benefit period maximum is $1,000 for just regular services, so the city is not, or the county is not on hook for any more than $1,000 for regular benefits. Your orthodontics, though, is unlimited, and there could be a chance that that may be where it's being driven from. So I can pull reporting, though, and find out what the main driver is there. Next, we're going to take a look at the reporting.
I'm sorry, I was just kind of looking here, and so we don't have individual stop losses on anything there. So we do that as a.
Well, in essence, we have the individual stop loss that's for everything except orthodontics. It's $1,000 a year.
Right.
But with ortho, we're unlimited right now, and she can take a look if that's what's driving our costs, and we may want to talk about.
You can cap that.
Having a cap on that as well.
Yeah, okay.
Okay.
Yeah.
Then behind tab 2, we'll take a look at the reporting. And this report is based off of your renewal periods, and it has 3 prior periods also so that you can do a comparison, and then it also compares you to the Wellmark benchmark of 989,000 members. And there on page 3, the executive summary, and I'm not going to go through every line on this, we'll go through it, just to give you some of the highlights. You look at the chart, the graph there on the right-hand side, you can see that 4 years ago, your claims were at paid per member per month were $5,194. Last 2 years have gone down and have been very consistent, but now we're starting to increase claims costs again up to the $4,802. Total trend for this current period is 6.7%, and mostly driven by the pharmacy side of it. If you turn over to the next page, then there's a breakdown of enrollment in the current period and in all the prior periods. Your average enrollment as far as employees has been your highest category, followed by dependents. Or your average members, I'm sorry, I'm looking at the wrong page here. So average employees, you're at 187, so you've been continually increasing that. Average overall membership is at 391, so that's every belly button that's covered under the plan. Average age is 34.5, and when you look at the benchmark, you're a little bit under the benchmark at 35.3. Average family size is right in line with the benchmark at 2.1, and that's been very consistent. So overall, membership, 48.7% of your population is female, with the average age of 35.5, compared to males' average age of 33. You can see on the right-hand side that most of your members are in Iowa, and there is 4 members currently located in Illinois. Then below that, it breaks out your employee, spouse, dependents by relationship and gender. And you're pretty much in line with the benchmark for most of those. On page 5, then your employee have been your largest category as far as overall membership for all periods, followed by dependents. And then on the graph there on the right, middle there, you can see that your largest age band is that 46 to 55. Your smallest is that 65 plus. Average employees by tier. Today you have two-way rates, so you have single and family. This is what it would look like if you broke it out to four-way rates. On the next page, then, we look at network performance, and overall, the county has saved over 50% in provider savings by using contracted providers. That equates to about $1.8 million. Members have been very consistent in staying in the network. You can see 99.7%, and in the prior years, it's all been over 99%, so that's very good. People are using participating providers, but in Iowa, it's hard not to find a participating provider. Then the top 5 service types by allowed charges per member per year. The ancillary services, those are inpatient services, so like inpatient therapies and things like that. And usually your inpatient services are the most expensive, followed by medical care, laboratory, surgery, and then accommodations. Then on page 7 is claims paid by range. And I like to point out this top line. These are members that have not had any claims at all. And it's been pretty consistent the last couple of years. In the current period, you have 47 members that had no claims, so that means they don't get a routine exam, they don't get a prescription, nothing. So not everyone needs to have a routine exam every single year. If you're in your 20s, you go to the doctor and you have a routine exam, everything's fine, your doctor will probably tell you to come back in a couple of years. So not too concerning with that, but you could encourage members to get that preventive exam because there is no cost share when you go have that routine exam done. Your largest category for the claims paid by range is the 5,000 to 20,000. Over 39% of your claims paid fall into that category. Then the next highest is at 20,000 to 35,000, and over 20% fall into that category. Then followed by that to 2,500 to 5,000. On the next page, we'll look at your spend overview, and that top left, allowed charges per member per year by relationship. In the current period and in the prior period, your employees were the most costly. The 2 periods prior to that, it was spouses. The top right has member paid versus plan paid. And in the current period, your members are paying about 9.5% compared to the Wellmark benchmark of 15%. So when you look at overall, but that you also have to look at the benchmark. We have a lot of high deductible health plans that are included in that, and those are first dollar until they've met their deductible, so that impacts that number.
And that does or does not include premiums?
This does not include
This is
premiums.
just dollars paid.
This is just claims, dollars paid, yep.
Okay.
And then,
It doesn't include administration, no, just claims dollars?
this is just claims dollars, yep.
Okay.
Then at the bottom left, your allowed charges per member per year trend by place of service. The top line inpatient, you can see that it has increased from 10% last year to almost 70%. And that's usually impacting, a couple of members are impacting those numbers, because those are your large claimants that are impacting that. Outpatient increased 5.1% in the prior period and then almost 2% in this current period. Office has gone down the last 2 years, so that's a little concerning. We would rather see members utilizing those office services because they are lower cost. So that's something that maybe encourage members to get a primary care doctor and go get their annual exams and things like that. The other category went up a little bit, and usually, the other category includes skilled nursing, home health care, ambulance charges, and that's usually tied to those members that are in the inpatient or your catastrophic members. And then there in the pharmacy, you can see that last year it went up 9%, current period's up 31.8%. Then on the next page, on page 9, as far as the spend overview, if you remember, the largest category that you had as far as population was at 56 to 64, and your smallest was at age 65 plus. And as far as claims costs, your age 46 to 55 is your most costly, but when you include everybody above that, above the age of 45, that's where your claims dollars are being spent for the most part. There was a few anomalies that in the 0 to 4, the prior period and a couple of years ago, that usually that's tied to a premature birth. That's where you'll see those costs come from. On page 10, your top diagnosis categories, allowed charges per member per year. And I'm just going to point out a couple on here that have increased from the prior period and are running higher than the benchmark. The abdominal pain, bones, muscles, ligaments, and bones, muscles, ligaments is Wellmark's top diagnosis category. So we see that as the largest category across the board for all groups, almost all groups. And it doesn't just incorporate older members where they're having their hip and knee surgeries. It incorporates younger population because they go out on the weekends and do sports and they injure their back or their knees and they have to have surgeries for that. So it incorporates a large population.
About chiropractic services.
Chiropractic falls into that category.
A lot of people utilize that.
Yep, they do. Then nerves, eyes, and ears are running lower than prior year, but still running a little bit higher than the current period. Obstetrical is a lot of your costs, and when we look at the large claims report, you'll see that. And then skin, nails, and hair is another area, and usually it's skin related, like psoriasis and things like that is what falls into that category. Then when you look at the bottom, at the totals, all 4 periods are running higher than the benchmark. On the next page, then it breaks that same report out by age category. And remember, your largest category as far as population was at 46 to 55. But you can see that at the totals there at the bottom, that the 0 to 4, the 19 to 25, 26 to 35, 46 to 55, and 56 to 64 are all running higher than the benchmark. The next couple of pages are inpatient reporting. It just focuses on inpatient services, costs, and utilization. Obstetrical is the main driver when it comes to overall cost and also allowed charges per admission. As far as utilization, again, obstetrical, and then mental health chemical dependency is impacting the average length of stay. The next page looks at diagnosis categories for inpatient only, and your benign cancers, tumors, and the bones, muscles, ligaments are the main drivers for the inpatient diagnosis. On page 15, it looks at your emergency room utilization. And there in the middle, on the left-hand side, paid per visit. In the current period, it's $441, so this is what is being paid per visit, and then member liability per visit is $233 for the same period, which is running, that's under the benchmark amount. Utilization, emergency room visits in the current period are at 114 compared to 103 last year and 136 the prior year. And you can see on the right-hand side, ER allowed charges per member per year. 3 out of the 4 periods you're running higher than the benchmark. Now there are a couple of things that we would like to see people utilize to stay out of the emergency room if it's not an emergency. We have the telehealth. the virtual visit service, which is available to use your smartphone or your iPad or your computer. And it's an option for the member to use before, if they're not sure if they need to go to the emergency room or not, they can use that in place of that emergency room. They can also use the BeWell 24/7, and then also call their family doctor. That even after hours, they usually have an answering service that will help them.
And that virtual one, is that, do you know what kind of response time you have with that? Do you have to place an appointment with that? How does that work?
You don't have to. Usually, the average wait time is usually 90 seconds.
Oh, wow.
Now, this last winter, with all the flu, it was longer than that. And I actually got the flu, and I got to use it. So at 6:30 in the morning, I was feeling crappy, and I'm like, I don't want to have to wait till 8:30 till my doctor's office opened. So I called them at 6:30. I waited, I think, 7 minutes. And they do give you an option to make an appointment if you want to, so you can. But talk to the doctor. I went through my symptoms, what was wrong, and then she prescribed the Tamiflu, sent it to my pharmacy, and my husband went and picked it up. I never had to leave the house.
Incredible. So, what is Wellmark's position on that? Do they encourage the usage of the virtual? Does it save dollars?
It does.
People like ourselves, and yet for the individual,
Yeah.
time and...
Yeah, it does. It's a convenience factor for the
Sure.
member, but it does save dollars. The most you're paying for an office visit is $45. That's what their charge is, and then the member pays their copay. So you would pay the difference, as an employer would pay the difference between that $49 and that their copayment. And it is a convenience. You don't have to drag your kids out. You don't, you can do it from your office. If you have an eye infection or something like that, it's for basic things. So it's not something you can overutilize, because if you're having abdominal pain, running a fever, they're going to tell you to go to your doctor or the ER or something. But it's just for like sinus infections, something that an eye infection, something that they won't.
It sounds like it'd be very good for the consumer for these
Right.
minor things you're talking about.
Yep.
And I just, does it show somewhere in here how much we're using it?
Yep, and I have a report that we'll look at here in just a
Great,
minute.
thank you.
But yeah, it's not an overutilized benefit by any means.
But maybe it should be used more.
But it's education and word of mouth and getting that information out to members. On this report here, it also has your top 10 primary diagnosis codes for the emergency room. And most of those, I would say, are emergency room diagnosis codes, but maybe the pharyngitis may not be, so that might have been an option for somebody to perhaps call their doctor or use the virtual visit or something like that to help offset some of that cost. On the next couple of pages, then, we have outpatient services. Overall the surgical category is the main driver there. As far as cost, utilization, it's medical. And your outpatient charges only increased 2% from the prior period, so it's not a huge increase from the prior period. Though if you look at the overall utilization and cost, you are running higher than the benchmark. And then on page 18, it has your diagnosis categories for the outpatient. And several of these are running higher in the current period and also higher than the benchmark. Injuries, poisonings is one, nerves, eyes, ears. Other category, radiotherapy, chemotherapy, a lot of that is done outpatient today. Skin, nails, and hair are another one. But when you look at the totals, in the current period, you're running under the benchmark as far as the total. Then the next couple of pages look at office utilization and cost. And again, remember, office has come down the last couple of years, where you're still running a little bit higher than the benchmark, but you can see that it's dropped quite a bit from 3 years ago. On page 20, it also has a chart there that shows your provider utilization, what your primary care, non-primary care, and then also chiropractic or fall into that category. So as far as diagnosis categories for the office on page 21, Most of these have come down, or all of them actually have come down, but there are still some running higher than the benchmark. Your blood, spleen, chest pain, glands metabolism, nose, throat, obstetrical, routine diagnostic is running higher than the benchmark, which is good. We want to see that happen. And then viruses and bacterial infections. And then on page 22, the clinical classifications, diagnosis codes. That top one, factors influencing healthcare, those are preventive services, and you can see that it's increased from the prior period and is also running higher than the benchmark. And then, again, most of these are running higher than the benchmark and have increased from the prior period as far as overall cost. If you look toward the bottom, the subtotal for the top 20, you're running higher than the benchmark in the current and in the prior period. And then when you add all of the diagnosis categories in, you're running higher in the prior 3 periods. On page 23, then we look at provider, at facility, and practitioner. There are the top 10 facilities in the current, that's comparing your prior period to your current. The current's on the right-hand side. Your Trinity here in Muscatine is your top facility in the current period. And then I also want to note that on the left-hand side, it has the University of Iowa 3 times. So in the current period, you have to add up those 3 amounts for that. And that comes to $184,000. So that would be your second highest in the current period. Genesis is also, the University of Iowa was the largest in the prior period, where they're second highest in the current period. Then at the bottom, it has the top 10 practitioners, all Iowa-based. And that Susanna Fremel is the top provider as far as claims costs in both periods. Next, we're going to look at some pharmacy information and pharmacy cost and utilization. So on this, we're looking at, if you look at the chart there on the right, you can see that, 4 years ago, you were right in line with trend with our benchmark. Went down a couple of years, and now it's starting to increase, and you're higher than the benchmark now. They're under the about 4 or 5 lines down, paid per prescription per trend, or paid per prescription trend has increased 42.2% in this current period, which is well above the benchmark of 7.6. If you go down 4th from the bottom, you can see specially allowed charges per prescription. In this current period, $9,355 is the average cost for those prescriptions. So they're definitely high dollar, and we'll look at some of your top, and most of those are from cancer drugs. On the next page, it looks at your generic utilization. It's 3rd from the bottom on that top chart. In this current period, you're at 86.9% generic utilization, which is right in line with the benchmark. So your members are doing a good job when it comes to just the regular prescriptions. It's those specialty drugs, which is hitting everybody. It's not just the county, it's every group.
Now, Devon, does the generic utilization only say when generics are being used, or when generics could be used because there are generics and there's...
These are what is being used. If you look down, I don't know that I don't have the report that goes into more detail on what could be. And usually that percentage is about 2% that members could replace their prescription for a generic. And I can get that reporting for you if that's something you want to look at.
You don't need to, I'm just curious.
Okay. Usually it's under 2% because there's so many more drugs that have come out as generic on the regular format of prescription drugs. It's just the specialty drugs are very few have generic drug available, and that's where we're seeing the biggest costs coming in.
Gotcha.
As far as costs and utilization by age band, your most costly or the highest utilization is at 46 to 55. They have the most prescriptions, but the most cost is at 56 to 64. Next, we're going to take a look at the drug classifications and also the top 20 drugs as far as cost. On page 26, that top category, those are your cancer drugs, your chemotherapy drugs. You have 6 claimants with 42 prescriptions and over $114,000 in paid claims. It makes up over 30% of your costs for those top 20. And then diabetics, diabetic medications and related medications are your second largest. There's 20% of these top 20 are diabetic related. And that's been typical. This is a little bit higher than what I typically see. Usually it's about 15 to 17%, but with your population, the age of your population, it's typical. The older you get, usually you run into more problems with diabetes. On page 27 then are your top 20 drugs. And that third column over tells you what is a specialty drug. And this top 2 are cancer-related drugs for chemotherapy. And those are your most costly. The one is Ibrance is over $11,000 per script. If you go down to Afinitor, that's another cancer drug. That's over $13 or $13,000 per script. That third drug, the methylphenidate, those are for ADHD medications. And we're starting to see an increase in utilization for adults in that category. So we're seeing an increase in cost there. Any questions on any of those?
Just the top 2 on page 27 are cancer drugs?
No, the fourth one down is also
The
cancer.
4th one also?
Anything that has antineoplastic agents
Got it.
are chemo drugs. There's another one down there that I'm not sure how to pronounce that one. That's about halfway down.
I
That's
see it.
cancer too. So basically, all your specialty drugs are cancer drugs. In most groups that I work with, there are also usually see rheumatoid arthritis, like the Humira, and those types of drugs. You don't have anybody in that category, which isn't not typical. Usually I see somebody in that category. Another one is MS for multiple sclerosis. That'll fall into this too.
I'm kind of surprised that the number of claimants on the insulins isn't higher for a group of this size and the age of the group. I don't know anything about it, but it seemed to me that it would be higher than that.
So insulin, that's one of the diabetic categories. Not everybody has to take insulin for diabetes.
I understand that.
Yep. But your incretin mimetics is also a diabetic medication, which is the fourth one down. Another one is, I'm going to butcher the name of it. It's right there in the middle. It's DEPEPTID. Yeah. That's a diabetic. Then the next one is blank, but I looked it up. That's a diabetic category.
Okay. Well,
And-
there's much more there than.
So there's more. It's
Yeah.
it's not just insulin related. You have several of them that are oral now that help maintain. I think you'll see the insulin more in the type A people because that's genetic. They have to take something like that to help control that. Where some of the type B, there's other medications available to them.
Sure.
Then on page 28, it has your large claims over $50,000 in the current period, and it breaks it out by place of service. And you can see those top 2, which are cancer patients. The pharmacy is the main driver for those members. And then the third one is another cancer, but the inpatient charges are your top driver for that.
Wowzy.
Then if you go a couple more pages back, and then I have a large claims report for all claims over $10,000 and several cancer patients, and then several obstetrical. fall into this report. Then, if you go back a little bit further, then there's a report that looks like this. This is the doctor on demand for the virtual visits. So it's still before tab 3, so it should be right at the end of it. Right at the end of tab 2.
You don't have it.
You don't have it?
Negative.
Oh, I apologize. I'll let you have this, but this is, it tells you how many people have registered for the virtual visit, how many people utilize it. So there's 7 registrations, and only 4 people have actually used it so far. It also breaks down the time of day that it's been utilized, the day of the week, male, female, the age, and on the back then it has the types of service that they had, so what they called in for, if they were prescribed the medication. So I'll just let you take a look at that. But it's a nice report, but yeah, it's not very utilized, and 4 people have used it so far since it's been in place. And I think we implemented that, did we implement that last year? So.
Didn't we have one time a little handout or flyer we could do on the virtual? Do we still have those around? Maybe we should redistribute.
Yep,
Not myself.
yep.
So we probably should redistribute.
Because they tell you how to do it, right? How to
Right.
set it up.
And it's easy that you download the app, and I would recommend that you download the app on your smartphone or on your computer now before you get sick, because when you get sick, you're not going to feel like doing it. So do something that can be something that can be done ahead of time, and that way you're ready to go when and if that ever happens and you need to see a doctor for something. Then tab 3 just has your benefits, and I'm not going to go through that today. Not a lot of changes from the prior period. We added, again, that coverage for 3D mammograms, and then just the mandates. Iowa mandates are what's changing for that. So if you go behind tab 4, I have some information on the Blue Distinction Total Care. And Blue Distinction Total Care today, when you go to a doctor's office, you pay your copay, and they want you to come in because they get paid more. So with the Blue Distinction Total Care, it's a value-based system, and it's something that you as an employer really don't have a lot of day-to-day things to do with it. It's very hands-off, but we do provide reporting to you. But the way it works is Wellmark's been doing this since 2014 with our fully insured book of business. And we've seen savings of $6 to $9 per attributed member per month in claims costs. So we've seen that savings for several years. And for fully insured, Wellmark's on the hook for the dollars. And in 2017, we rolled it out as an option for our self-funded employer groups. And we had a pilot program with self-funded employers to go through it and look at it to see what makes sense. And the way it works is if a member has a primary care doctor, and that doctor is part of one of our ACOs, our accountable care organizations, which you have Genesis and some other ones around here, but Mercy, Genesis, like I said, Unity Point are all part of our ACOs. And if you have a member that's got a primary care doctor affiliated with one of those ACOs, then they're considered to be attributable to this program. And what it does is we provide reporting to those physician groups. And that includes pharmacy reporting, that includes any medical care that they've had, whether it's, say they were traveling and they had an emergency room visit in Illinois. So they're not part of the Genesis or the Unity Point, but there's no way the primary care doctor is going to know that unless the member actually tells them. So they're getting all this information, all this claims data, pharmacy data, and we are providing reporting to their primary care doctor with all of that information so that the doctor can look at that and then see what the best treatment is for that member, and to, say, and I'll focus on like a diabetic. They can focus on that member's diabetic health to make sure that they're getting everything that they need to either maintain their health or improve their health. And we've seen, it get better as far as savings costs. That's again, that's $6 to $9 per attributed member per month. And with that, we ask that since you're a self-funded employer, that you help pay for some of those things to help incent the physician's office. So what we have goals for those medical groups, and if they meet goal or exceed goal, then they get an incented payment because they're doing a better job in maintaining that employee's health. If they don't meet goal, then they may have to pay back some money that they've received in the past. And we're asking that as a self-funded employer, since you pay your own claims and you're at risk for those claims dollars, that you help with that payment to those physicians. And we have certain measurements that we measure those ACOs on and make sure that, if they're meeting goal or if they're not meeting goal. We meet with the physician groups often, monthly and quarterly, to review data. And then they also get other information from other physician groups. So if we have a Unity Point out here that's doing, meeting goal, but you have Genesis that's exceeding the goal, those Unity Point doctors want to know why. They want to know what they're doing better than they are. So it's a way that they can share information and improve the health care of your members. But we are seeing a definite savings, and it's something that we have over 35 employer groups now, self-funded employer groups that are participating in this. So it's been an opportunity for those self-funded employers to partake in this. If you flip over to this page, and this is something new, Nancy, I don't think you have this in here. This shows the health of your population. This is Muscatine County's, it's behind Chatfield, so it's back a little bit. But this is your population health. So this is specifically to the county. And you can see that non-users, you have 9.6% non-users, and there's no claims dollars tied to it. Did you find it yet?
I'm sorry?
Did you find it yet?
No, yeah.
Keep going, you're
Yeah,
going
we're
right
almost
direction.
Keep talking, I'll find it.
One more.
So,
There you go.
and 33.1% are healthy, and that makes up 7.4% of your costs. The acute liner make up 18.9%, and your costs are about 12.7%. But then, your single chronic is about the same. Then you look at your double chronic, and you see that though the membership hasn't changed much, that overall cost has gone up to 41.6%. Your double chronic from our reporting is almost always diabetes with hypertension. So almost everyone that falls into that category has diabetes and hypertension. So that's where we're targeting that. And another, Blue Distinction Total Care, that's helping those members control their costs and hopefully either maintain or reduce costs and improve their health. The other three categories, your triple chronics, your malignancies, and the catastrophic, there's not a lot of control over those because they're in a condition where it's usually not reversible. So it's just maintaining their care and making sure they're getting the best care. But this is specific to to the county and shows exactly where your population is at. If you flip over to the next page then, it just shows you that your health plan members, you have 519 average health plan members, 49 non-users. In your blue distinction states, we do work with other Blue Cross Blue Shield plans. So I know on the previous report, there was 4 members located in Illinois, so we could potentially access those members through their blue distinction centers. And then we predicted about 21% of your membership can actually be attributed to the blue distinction. And then the next page that I have, this is what we estimate funding would be for that, for the blue distinction. And this does not include Unity Point population, so that would impact the numbers as far as how many people can be attributed. We think that there would be a few more that can be attributed. Since they were not part of the ACO in 2017, they came back on in 2018, and this was pulled before we had the data. But we estimate costs to be about $12.63 per attributed member per month. And for the monthly funding, the highest would be $1,500. And then for estimated annual funding, the estimated amount would be about $18,000. And again, we are seeing the claims dollar savings between $6 and $9 per attributed member per month. This is not a program that you want to go in for 1 year. It's going to take some time to see that savings, because that first year, the doctor's going to be contacting the member to make sure that they're getting everything that they need. They may be coming into the office more, but after that first year, we should see some savings. And as far as making sure that, by then the doctor should have, if they're meeting the goals and exceeding goals, they should be doing the things that they're supposed to be doing for that member, because they're getting that additional information from Wellmark as far as reporting and things like that. Some of the medical groups have actually hired additional staff to go through these reports to make sure that they're looking at the members that need the additional help and focusing on those members. So something to think about. It is a good program. We are seeing more people participate. And there's a PowerPoint there with additional information. It goes in basically the same information. I'm not going to go through that with you right now. But take a look at it, review it, and let me know, let Nancy know.
The cost that you talked about, the estimated annual cost of $18,000, do we pay that?
It's paid monthly. From
the beginning up front?
Yeah, the way it works is there is a 4-month lag time. It's because we have to get all the reporting, get all the data together. So there's a 4-month lag time. So it'd be July, August, September, October, November-ish, right around in there. That would be part of your self-funded billing. So it'd fall into a miscellaneous category on the billing, and paid on a monthly basis. And then if the providers meet goal after that, or exceed goal, then that money would go to them. If they don't, that gets held and carried over to the next period. So if they're not meeting goal, or if they're just at that meeting goal, you're not gonna pay that full amount. It would just be that goal portion. So if they go over goal, then it could be an additional amount. So it just depends on how the providers are doing, and we would have that in the billing reports as far as that type of information. And then after a year, we'll have more information as far as your attribution, what the costs have been and things like that. But it's going to vary from month to month, because people are going to be attributed to a primary care doctor 1 month and may not be for another month. It's not going to impact members that just go see a specialist, because it's just going to be the primary care, your family doctor, your pediatrician type doctors, your physician's assistants, those types of things. So if you have a heart doctor, you're not going to fall into that category. But if you do have a primary care doctor and you go to a heart doctor in a different practice, your primary care is going to get that information. They're going to see what prescription you've been prescribed and all that information, so that primary care can make better decisions with you. Any questions? Okay. The next then is the Naturally Slim program. And
Sounds like all of us.
that's what this is here. So you go behind the PowerPoint there, that still has the utilization codes there, information. But Naturally Slim is a program, it's a weight loss program, basically. But we have worked out of contract with a Naturally Slim who is owned by ACAP, and it's a pay for performance contract, basically, that if your members don't meet goal, you don't pay for them. You only pay for those people that actually meet goal. And when I say goal, is they have to lose 3% of their body weight in 10 weeks. If they don't, then you don't pay for them at all. Okay. So what it is, it's a program that initially we will work with Nancy just to see how we want to set it up, if we, how you want to roll it out. If you want to do a pilot program, you can roll it out to 10 people, you can roll it out to 20 people. You can roll it out just to members that have a BMI of over 25%. So there's different ways that we can set it up, but it targets members that have metabolic syndrome, so people with high triglycerides, diabetes, hypertension, so then there's some other categories in there, but it hits those people, and a lot of the population of the diabetes will fall into this. And with the type 2 diabetes, if you can lose, they found if you lose 3% of your body fat, it can drop you out of that metabolic syndrome category. It does help. When you look at the back of this page, it shows you that 84% of participants lose weight, 10.6 pounds is the average weight loss, and 83% of the participants maintain their body weight after the first year. You have something?
I don't think that page is in here.
Okay, you don't have that one either. But,
They're stealing all your thunder.
sorry. But, so the way it works is, once we get established on who we're gonna roll it out to, it basically works with those members on how to eat, when to eat, and where. And it changes their eating habits. So it's not just diet. They can eat anything they want to, but they have to do it in a certain way. And so after each bite, they put their fork down and chew their food. And then they can pick it back up and eat another bite. And then, but they've looked at people that are naturally slim on what their eating habits are and things like that. And they try and get members to focus on that. They have a weekly online class that they participate in. There's dietitians available, there's health coaches available, there's also behavioral health coaches available, so if people need assistance with different things, they have that. But it's just a weekly thing. It's about a half an hour to 45 minutes once a week that they go online and they go through the class, and they're given the tools to make it through the week for that. And then after 10 weeks, if they've met goal, then that's when you would pay for those members that passed or that met the goal. Then you wouldn't pay for anybody that did not. But then it continues for a full year. So it doesn't cut them off at 10 weeks. They have that support for an entire year to make sure that they're meeting their goal. And they've seen people continue to lose weight over that. And the cost for the program is $595 for those members that have actually met goal. And again, you don't pay anything unless they do. It's self-reported, and they found that most people, not over 95% of the people, are accurate. They want to once they start losing weight, they're like, okay, this is cool, and they want to keep doing it. And we've seen that as people do lose weight, then some other people start asking, well, how'd you do that? What are you doing? So and then when you have more than one person in an employee, they usually work off of each other to lose the weight too. So it's a program that we've seen that's been working, and it's something that's available to you. Again, it kind of focuses on that metabolic syndrome, but your diabetics fall into that category too. Those are your largest costs when it comes to overall claims. So it's an area that could possibly focus on that to help reduce overall costs. Genesis has been doing that for years out of the Quad Cities. They've had this program probably in place over 12 or 10 years. And
As
they
an
do it
employer or
as an employer. They've rolled it out to their community too. But this is the only one that does the pay for performance, that you can access, that you only pay for those people that actually meet goal. Questions?
Cool.
Well, last couple of things that I have in the book are Medicare supplement related. We do have some new programs available. I know you have an older population that may be getting close to that age 65. And there's information available here that they can get dental insurance now, vision insurance, and also hearing insurance over age 65 with a Medicare supplement plan from Wellmark.
Wow.
So this is new this year. So it's a nice plan, and it's fairly reasonable in cost. So that's something that's available, and Nancy's aware, and I think she has some brochures
You
that.
guys will get there someday, so just settle down.
Yeah, and Devon has provided me with some of these brochures, so if I have employees who are thinking about retirement, kind of don't know where to start, I have some information to provide to them.
And that's all that I have today. So what questions do you have for me?
Well,
Drinking from the fire
on
hose.
next week's agenda will be for you to authorize renewal, that take the formal action to do that, to set our rates as a self-funded, and then I'll also be asking you to make a decision about the two extra programs you talked about, the Blue Distinction and the Naturally Slim. So if you had questions during the meeting, if you let me know that.
So summarize Blue Distinction again. So Blue Distinction is trying to connect people more with a personal doctor.
Right.
And it's another layer of reporting and coordination. And what's the cost on that?
So the cost is that $12. It's an estimated cost right now because we have to pull current reporting to see how many
$12 a
people.
month per member?
$12.63 per attributed member per month. So only those members that actually have a primary care doctor. If they don't have a primary care doctor, you don't get charged.
So did you give, maybe I kind of spaced that off. Did you give us a results, what we've seen through this program? What benefit?
Right now, we're getting a $6 to $9 per attributed member per month savings and claims costs.
And the cost is 12 per what?
$12.63 per member per month. Or per attributed member per month.
Okay, so do that math for me. Okay, $12 a member, but I'm getting $6 a claim. So how many claims is an average member doing? Because it doesn't make sense to spend $12 to get 6, but I do that every day. So I'm helping me figure that out.
This is on the $6 to $9 is on average for the Wellmark book of business. So it's not going to
Right,
show.
got it. I understand, but so that we also, though, what's the average attributed member doing claims per year? Because that's, how much is that gonna?
Is it $6 to $9 per claim, or is it $6 to $9 in claims?
In claims
Per month.
per month.
So the cost is 12, and the average savings right now is 6 to 9.
And it's going to depend on your population as far as their health condition too. So when you look at the dollar to dollar, it's really not going to be able to tell you $69 per claim per attributed member per month and the $12.63 that you're paying out, because it's also going to depend on if the provider's meeting goal. If they're not meeting goal, any monies that you've paid in is going to carry over. So it's going to depend on if the provider is meeting goal or not, and things like that. And when I say meeting goal, that what we've seen is fewer hospital admissions, and a hospital admission is expensive, that's the most costly. So if you can keep one person out of the hospital,
So it's a cost avoidance thing.
right, right. Also fewer emergency room visits, and then it's a better focus on those chronic conditions. So it's not gonna be, you're not gonna look at one member and say, I'm saving only $69 per member, per attributed member per month, but I'm paying this much. That's not gonna give you the clear picture of what the overall cost is. You have to look at your population and also see what your trends are as far as inpatient services, your emergency room visits and things like
Well, I
that.
try to think about how do we try to judge the return on the investment? So if I look at the return on investment, there's a few things about us that you're not gonna change. You're not gonna change our demographics, and that
Right.
appears to drive a significant piece of our costs. Now, we have some, what I call the typical health issues, the hypertension, all probably weight related, you know. As people age, that just happens. So, I'm just trying to figure out, does it make sense?
When you say if they're not meeting goal, they don't pay, we're still gonna get billed, it just goes into a fund?
But you may not have to pay that next month. It's gonna
Okay,
depend on,
That was my question, okay.
I noticed that.
So you wouldn't necessarily be paying
I was
that
gonna
month
say
after
something.
month.
right.
No kidding.
20 pounds.
I'm supposed to weigh like 175 pounds.
Yeah.
But I can give you an example of a city that I work with. They started this program, it's been almost a year ago, and they have a member that's
Five of us should be the.
a diabetic, was in the emergency room over 30 times in 1 year because she was having a hard time controlling her diabetes. They've been able to reduce that down to about 15 times in the last year, so that's a reduction in savings. So it may be
Type 1 or 2.
type 2. They were just having a hard time controlling their diabetic
That's insane.
tendencies. But they've been able to reduce her her visits to the ER. So there's been just really one member that's maybe impacted the most by the program, where some of the others aren't going to be impacted as much. But that's one person less that you're paying, that difference in the ER visit too. So again, that $6 to $9 per attributed member, that's the average that we're seeing. You may be better, you may be worse, I don't know. That first year, you're not going to have a savings because your members are going to be going to the doctor more, we would hope, to help either maintain or improve their health. But it would be after that you would start seeing some claims savings. So it's not something you can look at just as a 1 year basis. It's something that's you need to look at is your overall health for your members over several years.
Well, the biggest solution on healthcare overall is if they made drive-up windows illegal.
There you go.
And that's not
Do you
even
have
a
a program
joke.
that does that?
You want to call in Bloomberg and his New York posse
Well, I
to
was
see what
gonna
else
say,
they
you
can.
need to go to New York.
How else can we protect ourselves from ourselves?
Well, I mean, it's just,
Make them walk up windows.
yeah,
They'd get no use.
it's kind of crazy.
Okay.
Thank you very much.
Thank you.
Thank you, Devon.
That's a lot of.
It's like drinking water.
boy.
We're gonna have this all digested in a week.
Okay. Is there anything else to come before the board? Seeing nothing else, meeting adjourned.